And then now for our con position, we've got Dr. Basir coming up to say we should focus on one problem at a time.
All right, I just met Salman, such a nice guy. Sorry, I'm gonna have to destroy him here. So, oh, these are not my slides. If someone can quickly change them, that would be great. These are Shashank's slides.
That's part of the challenge.
You know what? Honestly, I don't need any slides. So, I am not a critical care cardiologist. I'm an interventional cardiologist, so they did up the game as it comes to this debate. But really, there is no debate. All of the data supports the fact that you should minimize the amount of revascularization that you do in an acute AMI cardiogenic shock patient. So when a patient presents with an acute AMI and cardiogenic shock, they present in a very vulnerable state where their major problem is hypoperfusion to their end organs. And that hypoperfusion to their end organs needs to be restored. And the goal of your mechanical circulatory support device is to essentially allow for that perfusion to start and to be able to protect yourself or to protect the hemodynamics, to not have your patient crash and burn as they're actually undergoing revascularization. But we've done a lot of complex hemodynamic studies in patients to essentially demonstrate the effectiveness of mechanical circulatory support as it relates to complex interventions. And so even though I don't have the slides right now, but you'll have to believe me, use of hemodynamic support device at low levels compared to high levels improves coronary perfusion. It improves perfusion to blood vessels that are stenosed, even up to 95% stenosis. That is more support than what you would get from an intra-aortic balloon pump, where they were only able to augment coronary pressure to about 50% stenosis. And the hemodynamics within those scenarios allow for you to do more revascularization. But that's in a very stable and controlled setting where patients are chronically decompensated. When patients are acutely decompensated, what we do within the cath labs in terms of coronary intervention has an immediate impact on the patient. And so we've done pressure-volume loop relationships where we've actually shown that as you do atherectomy, for example, in a patient's blood vessel, the volume within the LV doubles. And the pressure drops by, in the case example I had, of about 40 millimeters of mercury. And so it's substantial changes that are occurring within that setting. And so even though, as Salman showed really nicely, you can do a lot of complex interventions with hemodynamic support, when you're in cardiogenic shock, that's not the time to do it in. You should allow your patient to recover, and maybe you stage that intervention, or you maybe even do it before you take out the support device, but you definitely don't need to do it acutely in that setting. And then the CTO intervention is really not needed in that setting as well. So all of the data is supported by my position. So the first trial that I'll mention is the culprit shock trial. And the culprit shock trial actually randomized patients based on this strategy. And I'll argue with you, and it's a criticism I have of the trial, that it's actually an unrealistic expectation that the investigators had. So the complete revascularization arm spent time opening chronic total occlusions. They were highly unsuccessful, and they were only able to open less than 50% of chronic total occlusions. But not just that, they required a lot of contrast during those episodes. They required an average contrast of around 280 cc's per case. And so the primary endpoint of the culprit shock trial was not just mortality, but acute kidney injury. And so there was no difference in outcomes between those who were treated with complete revascularization. In fact, there was slight harm within that group. And so that is the most definitive trial that we have to date. Now, that trial in and of itself, I don't think answers everything. We looked at the multi-vessel PCI that was done out of the National Cardiogenic Shock Initiative. And we demonstrated within that study that selective multivessel PCI may need to be done in patients with cardiogenic shock. And the reason that that's the case is because sometimes there's dual culprits. Sometimes you may have an acute RCA infarct or circumflex infarct, but you have a 90% proximal LAD. And in those settings, you could definitely make a clinical argument that the shock is being driven by the remainder of the coronary artery disease that's there. And in those settings, it is really important to use hemodynamic support compared to not using hemodynamic support. So going back to this question of CTO intervention. So Shashank, who was supposed to give this talk, is an advanced heart failure critical care physician. Well, I'm a high-risk PCI operator. I do complex PCIs every day, and I do not do chronic total occlusion intervention in any shock patient in my recent memory. And the reason for it is because 25% of patients who have come to the coronary cath lab actually have a chronic total occlusion. And out of those, when we do go on to revascularize those patients, we have a mortality of about 1 to 1.5%. And the complication rate with aggressive CTO PCI that was done by national leaders is around 7 to 8% risk of perforation. And clearly, as we've debated the danger shock trials and the impact of complications as it affects those outcomes, clearly doing non-infarct related interventions and causing complications within that subset is really very problematic. And so I really feel very strongly that the data and the kind of common sense aspect of treating patients really requires us not to do that much intervention in patients who come in AMI cardiogenic shock. And to Salman's credit, because he's an amazing operator who I personally learned from as well, it's really important to just keep in mind that staging these patients and revascularizing them after they're out of their acute coronary syndrome can lead to better outcomes, and that is going to be studied even further in the PROTECT 4 randomized control trial, which has, as of, I believe, yesterday, 87 more patients to enroll, and will be a really game-changing trial for us in the future. Thank you so much.
All right, that was outstanding, and your slides did just come. If there's anything you want to show us. But that was outstanding, and I think it's a really important question, so why don't we let the panel first weigh in.
So I've heard both point of views, and both are quite interesting. Regarding the culprit shock, I mean, to my understanding of that trial, none of the patient was really supported by any mechanical support at the time they were randomized. So the question here is, in patients supported by MCS, do we have some benefit or not? So I understand the fact that when you give more contrast, you may have a little bit more acute kidney injury. You also mentioned that you may have more contrast, so more dilation of the ventricle. But if you use the impeller, you have less dilation, so this will not be worrisome, I think, for this aspect. So the question is, to which extent can we really extrapolate the unexpected result of the culprit shock trial to the patients really supported by MCS, and for which, as you mentioned, sometimes you have indeed several vessels that can be implicated in the problem. So I understood that you adapt your situation to the patient you have in front of you, so you don't go for routine, but in selected patient you still can consider that you will go for it?
Yeah, I think in select patients it's different as long as you believe that coronary disease is actively contributing to the cardiogenic shock that's in front of you. But I don't think that we should take away that revascularization with support is benign, right? Because for every balloon inflation that you have, you actually shift the pressure-volume relationship towards the right. And so you're having lower blood pressure, higher volumes within the ventricle. And what we've shown in other studies is that actually if you lose pulsatility during a high-risk intervention, your risk of MACE over the first 90 days is actually much higher. It actually almost quadruples. And so those patients really need to be monitored really closely. And we actually can argue that they should have advanced heart failure follow-up as well because their long-term outcome may not be very great. But I think ultimately the decision that we're making as proceduralists is the coronary disease in front of you actively contributing to this patient's shock? And most of the time, I think that that chronic, long-standing disease hurts patients more if you revascularize them in a vulnerable position as opposed to supporting them, letting them come out of shock, have more improved hemodynamics, and then going back and taking care of that disease.
So I'll just make a point that I can't defend you from myself from there. I agree with you 100%. So, I mean, debate aside, I'm here on the other side of the microphone.
There you are.
No, but I didn't have a microphone there. They don't have a microphone in the center of the room. But no, I think I agree with you. And to both of those points, again, in our patient, we brought him back 4 days later. It wasn't right away. And had the debate been, should we revascularize CTOs during active cardiogenic shock, the answer would have been no, we shouldn't. So I think, debates aside, I agree with 100% that these should be well thought out decisions because many times you don't know if that CTO is going to improve the perfusion state or not. And now, sometimes you have a CTO, for example, that involves an RCA that's very small, non-dominant, or supplies a small PDA. That's not the one you need to go after. But a patient like ours who only is living off of CTOs and one ramus, that's a case where you do want to go for that. So in our hospital, we work closely with Dr. Carr and Dr. Jumian's team, so it's always a multidisciplinary approach. But I will push back on a few things. The CTO PCI complication rates are very low. 7%, if your operator is having a 7% perforation rate, they need to go back and learn some newer techniques because that is highly unusual. The technical success rates are upwards of 85% depending on all-comer population. And you can do these with low contrast. And not necessarily speaking to any particular program, but even within CTO PCI, we've gotten good enough to the point where we can do this safely, and sometimes that means staging the CTO PCI over 2 procedures, perhaps.
So I wonder whether in a naive, I'm not an interventional cardiologist, of course, but I wonder if I could shift the debate a little bit. I mean, it seems to me that mucking about with a CTO in an initial PCI of cardiogenic shock doesn't sound like a good idea. I will say that I asked Dr. Tila directly whether he regretted including them, and what he said was, all the mortality was in the people with the CTOs, as it's in the data you showed. But what do you think about doing a non-culprit, non-CTO in the acute setting? Because you have a little disjunction. In acute MI without cardiogenic shock, you're supposed to do them, but in cardiogenic shock, maybe you don't. So you think that that's intrinsic to the cardiogenic shock, but if you were supported and if you had a relatively stable patient, do you think there's any point at least thinking about doing a non-CTO, non-culprit in cardiogenic shock? Because you would like the other walls to move.
Maybe I'll jump in on this. And I like Sandeep started this session with debates about no absolute facts or eternal truths, or was it the opposite way? But I think it's this complete revascularization in AMI, shock or no shock, is fascinating because we went from not indicated to indicated and indicated to not indicated, right? For cardiogenic shock, indicated, now class 3. And the opposite way for non-shock. And so it just shows you that how complex this is involved. So a couple things. Multivessel disease is common. So in shock, it's 80%. In regular STEMIs, it's about 50 to 60%. 2, I think the data shows, both shock and non-shock, that ultimately complete revascularization is important. So if you look at the culprit shock data over the course of a year, the non-culprit, doing only the culprit, there was an increased need for subsequent revascularization. So I think complete revascularization is important for both groups. The question is the timing. And I really think, looking at this very much, this is super judgment. It's not just vessels, it has to do with what time of day is it, what's the underlying hemodynamic status, what's the creatinine, what's the size of the non-culprit territory. All those things go in, and it really, I think, ultimately is judgment. And I think if it's a questionable thing, err on the side of doing the culprit only, because there's no hurry in the most cases. There is a group of patients in our network that we have about 2 to 4% have more than one culprit, and that's in a unique status. But so I think this is a challenging area where it really comes down to judgment.
Can I just add something? So I have to congratulate both the debaters, because this is the only session out of the ones we've been sitting here for where I think that they did have a common unifying thing at the end, which is the word routine is what gets us in trouble here. Is that I think both of you mentioned that every patient is different. Every CTO lesion or non-culprit lesion that's not a CTO is different. And what it takes to revascularize that could be something that's relatively straightforward, whether you're on MCS or not, versus something that you almost wish you hadn't gotten into when you start. And I think both of you kind of nailed it when you said that what's the goal we're trying to achieve here by going after this lesion, whether it's an easy one or not easy one. Because at the end of the day, we look at the short-term outcomes most often for these patients in shock, and the complete revascularization, again, touches more so on what's going to happen next or thereafter, or in the year after, as you mentioned, Dr. Henry, with repeat admission or repeat revascularization down the road. But for these patients, CTOs, as we know, they are changing. You know, the outcomes, as you mentioned, the techniques have changed, the procedural aspects have changed, and there are improvements. But at the end of the day, it is guided per patient as to what's the goal here, what's the objective for this person, because Dr. Rain mentioned it as well, it's definitely not mortality for these patients. So,
well, one can argue right now that, at least with the CTO research that we have, it's very reasonable to question even whether CTO PCI should be done in this setting if the patient has minimal symptoms. So me and Salman are on the same page. We do a lot of complex coronary artery revascularization, so we're not having that debate amongst ourselves. But I think putting on my academic hat and talking about it as a holistic disease state within the group, I think it's really important to know that the only benefit that's actually been shown in the randomized control trial was the EuroCTO trial, which showed a benefit of symptoms. And so the revived BASIS trial, which included a lot of asymptomatic heart failure patients, actually showed no benefit in complete revascularization as it relates to EF recovery. Now, we have other observational studies that have shown maybe there is some better EF recovery, but it's probably not on current standard guideline-directed medical therapy. So I think that this area of revascularization within heart failure is really up for a lot more debate and discussion. And we have good data on as it comes to CABG, but you're not doing selective revascularization in CABG. When you go in, you're doing it all as much as you possibly can. When it comes to revascularization and risk-benefit, when it comes to interventions, it is much more nuanced debate about how much you do and how much is beneficial for these patients, and I don't think we can actually answer that question.
No, and I would agree with that. I mean, I think ultimately the takeaway message should be that CTOs are not always benign, and CTO PCI is successful, and it should be discussed as a group. And to your point, you know, the non-culprit, non-CTO versus CTO, it depends on the CTO also. I think the complications you run into are those crazy epicardial retrograde. You don't need to do all that. I mean, if that's what you have to do, then perhaps you should stay away from that. But patients like this, if you stabilize them, and now you say, you know what, tomorrow I'm going to take the impella out. Well, ask yourself, well, is there anything I need to do before the impella comes out? Because there's a whole group of procedures you do, let's put the impella in so I can do this procedure safely. So I think it's very nuanced, and as with anything this complicated in today's world, you just have to take a multidisciplinary approach, but make sure you have a CTO proficient operator as part of the decision making, and as well as heart failure, obviously.
For both our panelists as well as our debaters, so let's say the dust settles, you're 48 hours out from your index PCI, you address the culprit alone at the time, not a great deal of dye, you're contemplating bringing them back for complete revasc before the impella comes out. Does viability sway your mind at all? Is it worth looking in this population if you've got the time to do so before you take this out?
Well, Revive would suggest no, that viability does not predict who's going to do better. What we do is and this is obviously if the patient has a device and is different, but for patients who survive and then the sort of an outpatient setting or inpatient, we typically do a PET scan to see the ischemic burden. So ischemic burden of the CTO, I think, is more important than viability. And as Revive showed, if you're not infarcting, like if you're not ischemic, even though you may not have viability or you may have viability, I don't think that affects the outcome. That's my reading of the data. I don't know, Babar.
I completely agree with that. I think really in the acute setting, the only thing that's helpful from a viability study is if it's non-viable. And I am a personal believer that at least from revascularization for with PCI, you should not do revascularization in any setting, including if patients are having symptoms to an area that is non-viable by PET or MRI.
All right, 3 outstanding debates, and we're on time. So.